Hello, my name is Rachel Sykes, and today my presentation for the Pharmacology Drug Category Project is going to cover HIV. This is for Advanced Pharmacology, Nurse 60110, University of North Georgia, Fall 2022. HIV stands for Human Immunodeficiency Virus, which is the virus that causes HIV infection. HIV attacks and destroys the infection-fighting CD4 cells of the immune system. The loss of CD4 cells makes it difficult for the body to fight off infections and certain cancers. Without treatment, HIV can gradually destroy the immune system, and HIV infection advances to AIDS. HIV transmission is only possible through contact with HIV-infected body fluids. Best practice guidelines for HIV infection is antiretroviral therapy. Antiretroviral therapy is recommended for all individuals with HIV to reduce the morbidity and mortality associated with HIV infection and to prevent HIV transmission to sexual partners and infants. ART should be initiated as soon as possible after HIV diagnosis. Once initiated, ART should be continued with the following key treatment goals: maximally and durably suppress plasma HIV RNA, restore and preserve immunological function, reduce HIV-associated morbidity and prolong the duration and quality of survival, and prevent HIV transmission. So we know that the goal is to actually suppress as much as the virus as possible, so to get that viral load almost undetectable. And if we can do that, then the patient is capable of having a good, strong, healthy immune system to be able to fight off any type of infections that come their way. And then also, if the viral load is undetectable, then they are less likely to transmit the virus to other people. Your first-line drugs. An initial antiretroviral regimen for a person with HIV generally consists of 2 nucleoside reverse transcriptase inhibitors in combination with a third antiretroviral drug from one of the 3 drug classes: an integrase strand transfer inhibitor, a non-nucleoside reverse transcriptase inhibitor, or a protease inhibitor with a pharmacokinetic enhancer. And you can see some of the examples that are listed there. For your second-line therapy, second-line antiretroviral therapy is only used when patients develop treatment failure for first-line therapy drug regimens. And then what's recommended for second-line is a boosted protease inhibitor plus 2 nucleoside analogs. And it gives you some examples there about what to try. So, like for example, if stavudine and zivudine has been used in the first-line therapy, then you would actually move to tenofovir disoxypryl fumarate as the NRTI in your second-line therapy. So it kind of has a little algorithm that you would use for that. Pharmacodynamics and pharmacokinetics. So most of these medications are metabolized through the liver and then excreted through the urine and some through the feces. So your nucleoside reverse transcriptase inhibitors suppress HIV replication. Your integrase strand transfer inhibitors prevent insertion of HIV DNA and stop the replication of HIV. Your non-nucleoside reverse transcriptase inhibitors stops the ability of nucleosides to bind, which inhibits DNA replication and promotes premature termination of the growing DNA strand. Your protease inhibitors actually blocks the HIV enzyme protease, and so it causes the virus to remain immature and non-infectious. Effects on body systems. Your nucleoside reverse transcriptase inhibitors, side effects could be headache, nausea, vomiting, fatigue, malaise, sleep disorders. Your integrase strand transfer inhibitors, headache, nausea, fatigue, weakness, and CK elevation. Your non-nucleoside reverse transcriptase inhibitors, rash, depression, nervous system symptoms, convulsions, headache, nausea, vomiting, fatigue, dizziness, impaired concentration, sleep disorders, your protease inhibitors, skin reactions, hepatitis, diabetes, headache, nausea, vomiting, abdominal discomfort, diarrhea, rash. Economic factors of HIV. It's a great article that I found through the Clinical Infectious Diseases. And basically the result is that despite early ART initiation, a projected 1.39 million new HIV infections will occur at a cost of $256 billion over the next 2 decades if HIV care stays at this existing level. Their conclusion was that failure to improve engagement in HIV care in the United States leads to excess infections, treatment cost, and death. Interventions that improve not just screening but also retention and care are needed to impact the cost effectiveness of HIV. Considerations for special populations. Adolescents and young adults have lower rates of testing, diagnosis, treatment than adults with HIV. So some strategies to improve their medication adherence would be simple regimens like a fixed dose once daily combination, and then encourage them to download an app on their cell phone for a reminder or certain pill boxes for adherence support. Your older population with HIV, additional medical and social services may be required to effectively manage their HIV and then other conditions they may be experiencing. We have to watch out for adverse drug events from ART with their other medications. Polypharmacy is very common in your older persons, and then watching them for their neurocognitive function. Women with HIV, clinicians should consider that some antiretroviral drugs have significant interactions with hormonal contraceptives and hormone replacement therapy. Clinicians should consider the possibility of weight gain in women when initiating or changing ART, and then when evaluating the regimen of ART for women, clinicians should consider the regimen's effectiveness, the woman's hepatitis B status, and then the potential of passing on side effects to the mother and the fetus. Here are the references used for this presentation.